welcome to the talk. The talk is an approach to common and not so common rashes in the office setting. I'd like to introduce Dr. Christy Freeman. She's a family physician in Peterborough, Ontario, with a full-time focused practice in dermatology. Dr. Freeman completed her family medicine residency at McMaster University in 2000. She also obtained her diploma in practical dermatology from the University of Wales in 2003, and then went on to do a Master's of Science in Dermatology from the same institution in 2011. She's been working full-time in the area of dermatology since 2004 and is an adjunct professor for the Queen's Family Medicine Program. So I'd like to welcome Dr. Freeman.
So I don't have any conflicts of interest for this talk. I'm mostly going to talk about diagnosis today and not too much about treatment. And I just want to apologize for that, but we only have so much time. And I think once you have a diagnosis, you can always look up the treatment, but sometimes it's coming to that diagnosis that's the tricky part. So in terms of our objectives, we're going to try to develop a list of differential diagnoses for some of the common skin eruptions that we see in the office. We're going to talk a bit about an approach to our history and our physical examination and how we can use these to narrow our differential. We're going to talk about what appropriate investigations we can use to help us come to a diagnosis. And then I'm going to briefly just talk about sort of quick first-line treatments for the conditions that we look at. So when I was thinking about the title for this talk, I used the very unscientific word rashes, because there's something about the word that just kind of, I think, like builds some kind of emotion in us. And I think for many of you here, probably it's negative, and that's probably why you're here, right? So we see that rash, we go, oh, darn, because they're tricky, right? And they're tricky because there's lots of different skin eruptions that look really similar to one another. It's because even the same diagnosis can look really different in 10 consecutive patients. Also because we can't just look, we have to listen, and sometimes our patients are very distressed when they have a rash, and it's hard sometimes to get the information and the history that we need. And there really isn't a great evidence-based approach or algorithm, so sorry, right now I'm not going to give you that magic algorithm to solve all your rash problems. So we really just have to start to build a repertoire of images in our head that we're going to match up with some little tips and tidbits from our history and physical. So coming up with that differential diagnosis is key, and I would suggest that we kind of need to work in reverse. So I think that we need to collect a database of images in our minds that we can then store, and when we see these patients in the office, we can try to match them up. So that's what we're going to do to start with. So clearly this is not an exhaustive list. So we're going to start with tinea corporis. And of course it's annular, and I mention that first because I see a lot of referrals, and if the rash is annular, it is always tinea. But of course that's not the only criteria. So I encourage you to look beyond the annular, and remember that we're also looking often for an erythematous or active edge, and that edge is active in the sense that it's often expanding. The patient might tell you that these patches started much smaller and they're growing. And oftentimes these lesions are scaly, especially at the edge. And it's sort of a fine scale that we can see. Sometimes it's hard to even perceive that they're scaly until we start to scrape them. Patients are often itchy, but not as intensely as they might be if they had a dermatitis. And remember that these are quite easy to diagnose if we can do a skin scraping and send it for KOH. We may have to wait for that result, and we can treat empirically in the meantime. But just in case we had it wrong the first time, that skin scraping will serve useful to us a few weeks down the road. A biopsy, of course, will diagnose it well also. So just a few more pictures of some classic tinea corporis. And of course, we treat these with topical antifungals unless they're very widespread. And sometimes 6 to 8 weeks is required, so encouraging our patients not to give up too soon. So atopic dermatitis, another really common eruption that we'll see in the office, often in children, but remember we can certainly see it in adults as well. And so this will present with some dry, often pink patches. Often you'll see excoriations within the patches themselves because the patients are scratching because they're very, very itchy. It's most common to see these in the flexures, and often we see symmetry with atopic dermatitis. These patients are often colonized with staph, and so one tip is that if you're considering treating for secondary infection, treat based on your clinical exam. So if these patients are having a sudden flare, their skin is beefy red, maybe they've got a bit of crusting, go ahead and presume that they're secondarily infected, and do your swab only to make sure that they're not colonized with MRSA. But don't treat based on swabs, because oftentimes they'll swab positive all the time. So base it on your clinical exam. And just a few more pictures of atopic dermatitis. Of course, we treat this with emollients. I encourage the patients to moisturize twice a day. We use topical steroids. And don't forget our calcineurin inhibitors, especially that picture of the dermatitis around the eye. A lot of patients say, well, I was told I couldn't use anything because I don't want to put steroids near my eye, and that's certainly wise. But remember that we do have calcineurin inhibitors, trade names Elidel and Protopic, and they're excellent choices to use around the eye, and they work really well. So nummular dermatitis, another annular rash. So oftentimes we call this discoid eczema, and this is more often seen in adults than children. It's also very itchy, so you may see excoriations. And rather than just having a fine scale like our tinea did, this is going to be more crusted. So think of it as a more thick crusting scale. You may just see one or two of these lesions, perhaps on the lower legs, and other times it can be quite diffuse. So doing a skin scraping, if certainly tinea would be on our differential for this photograph, of course it will be negative and that will help us. Also a biopsy would help distinguish this from tinea. And here are some other classic pictures. So again, hopefully you can see in the images that there's that sort of crusted appearance to the surface. One of the tips with these patients is they really don't respond well to low potency steroids, so you really need to choose medium or high potency. Their itch is really too severe and you'll find they just don't improve. And of course, just like with the kids with atopic dermatitis, you want to encourage them to use the emollients twice daily. Another annular rash, so psoriasis. So these annular lesions are often very well defined, sharply demarcated. It's one of the ways we can tell them apart from things like our tinea and our nummular dermatitis. The character of their scale is also different. So we see this silvery scale, which sometimes can be quite thick. Other times, to confuse us, it can be quite thin. We also want to, when we see one or two of these lesions, let's say on the torso, the patient pulls up their shirt, we want to start looking for the hot spots. So we want to look at their elbows, look at their knees, look at their sacrum. So there are certain specific locations that we see psoriasis in more commonly, and that can really help us come to our diagnosis. If we're not sure, a biopsy will certainly distinguish between psoriasis and tinea or dermatitis. So here's some pictures of some nice thick classic plaques on the knees and a photograph of the areas where we're most likely to see psoriasis. So again, we need to use sort of medium to medium high potency topical steroids to have much of an effect, especially with our thicker plaques. We could also use our topical vitamin D analogs, narrowband UVB, and then for our patients who are more severely affected, you're going to consider referral for systemic immunosuppressants or biologic agents, still often used in combination with topical therapy. I've chosen a great day to lose my voice, sorry. So guttate psoriasis, also annular. Much smaller though, right? So we see these really small pinpoint lesions, although sometimes they do coalesce into larger plaques, and so some of them will look more like typical plaque psoriasis. Usually we're seeing this eruption in children or maybe in young adults, and it comes on quite suddenly. They're usually very distressed because it can also affect the face and often the scalp as well. Some of them are quite itchy and others actually have very few symptoms. It's usually the appearance of this that is more upsetting for them. So one thing that I always like to mention with guttate psoriasis is to try to resist the urge to treat this with prednisone. We really want to avoid prednisone in any of our psoriasis patients because sometimes it can trigger pustular psoriasis, which can make our patients quite unwell. So even though this is very widespread, we do still just use medium potency topical steroids. And if your community has access to narrowband UVB, they do really well with that treatment. It's of course self-limited regardless, but patients want to get rid of it as quickly as they can. If you don't mind, can we wait to the end for questions? Okay, thanks. So this is another really widespread eruption, finally not annular, and this is a medication reaction. So we're going to see these more often in our older patients, often with polypharmacy. Usually they start within a week to a month of the initiation of a new medication, but sometimes it can be much later than that, and that of course makes things a little more confusing for us. Some of the most common medications to cause reactions would be our beta-lactam antibiotics, our sulfonamides, NSAIDs, hypoglycemics, thiazide diuretics, allopurinol, and anticonvulsants. Allopurinol is a really big culprit, so even if you can only remember one thing on that list, that would be the one that I would remember. So of course the treatment in these cases is to discontinue the offending medication, remembering that it may take several weeks for their eruption to disappear. Sometimes I see patients, and perhaps on their own or with the help of a healthcare provider, they've tried discontinuing a medication for a week, and when they don't see a significant improvement, they go back on it. But I'd suggest trying to keep your patient off the potential offending medication for a month to really know if you're on the right track. So you can use topical steroids in the meantime, of course, to help them, and if it's quite severe, consider prednisone. So scabies. Scabies can actually be really difficult to diagnose. It seems like it should be an easy one, but it's not. Of course, it's acquired through contact with other individuals who have the mite, or it could be through fomites, because these little mites can live for several days off their host. And they itch pretty soon after they get infested. It generally affects people from the neck down, and there are certain sort of common locations that we probably all know to look for. So between the web spaces, on the feet, on the wrists, and we look for burrows. So they're gonna look like a track, and that's often where there might be a mite or that might contain eggs. We of course treat this with our 5% permethrin, applying from the neck down for 8 to 10 hours overnight. And even though they might tell you that only one other person in their family is itchy, anybody who lives in the household should be treated. And of course they have to do the big wash the next day of all their clothing and bedding and put it in a hot dryer. Anything that can't be washed, I tell them just avoid it for a week. Some patients who have their scabies infestation for longer periods of time will go on to develop these scabetic nodules. And this is more of a widespread allergy that they're having to the mites. It takes a little longer to develop, so this is usually several weeks afterwards. These nodules, again, have some specific locations that you can look for. So if you see them in the axilla, the groin, on the genitals, that can be quite suggestive. And again, you can see in this photo, there's excoriations all over the place as well, because these patients are very, very itchy. A biopsy can be helpful, but it's not specific. It's going to show lymphoeosinophilic infiltrate, which can be the case in a dermatitis or an immunobullous disorder as well. We have very few mites actually on the skin when we're infested with scabies, and so the chances of catching one in the biopsy are slim. So we have to put all the pieces together in terms of location, itchy contacts, and our biopsy. If you have a dermatoscope, there's a little trick that sometimes is helpful. So if you can find a burrow and look with your dermatoscope towards the end of the burrow, you can see, it's a little difficult on the screen, I think, but you can see those little brown triangles that the arrows are pointing to. So those are actually the mites. And you can also see the arrow pointing towards some eggs. So that's sometimes another way, if you're suspicious, is find a burrow and look with your dermatoscope. So contact dermatitis, so that's an acute dermatitis that's onset by contact with a substance to which the individual's previously been sensitized. And of course, you can have a contact allergy to almost anything, but there are some more common contact allergens, nickel, preservatives, fragrance mix. MCI is becoming really common, which is an ingredient that we find in wet wipes. I find a lot of my adult patients seem to be using wet wipes now and having reactions to them. This photograph is, I think, trying to show that the adhesive we use in artificial nails is another common cause, so that's why she's holding her beautiful nails up to her itchy eyes. Sometimes we get contact dermatitis very soon after contact with the offending substance, and other times it can take 3 or 4 days, which again can sometimes make it tricky for us and for our patients to figure out what caused it. patch testing as opposed to allergy testing, where they put little bits of many of these common contact allergens on the back and bring the patient back for several visits to observe them, can be helpful in terms of identifying the offending agent. This would be something done in a dermatologist's office if you have one in your community. This is just showing a nice picture of shoe dermatitis in a patient who was reacting to her footwear. So contact dermatitis, of course, if we can figure out what's causing it, we want to remove that from the patient's environment. And then we're going to treat it with our generally medium potency steroids, or if it's on the face or folds, like that last woman with her eyes, think about your calcineurin inhibitors. If it's a really widespread eruption, then giving them a higher dose of prednisone with a taper, as well as topical therapy. I see a lot of patients, I find especially in Emerge, who have really widespread, let's say, poison ivy, and they're given prednisone, but they don't ever seem to be given a topical agent, and prednisone does still take some time to work. So just to encourage you to go ahead and do the prednisone, but also give them a reasonable strength corticosteroid to help relieve their itch while it's working. So keratosis pilaris. I try to explain this to patients that it isn't really a skin disease at all. It's really more of a skin type, and it is genetic, so they can blame their parents. And usually this becomes most prominent in the adolescent years when they unfortunately are much more aware of their appearance. So they can be quite bothered by these little follicular papules that often have a little bit of a dry white head on them on the backs of the arms. Sometimes we see them on the jawline, and other times also on the thighs. They're completely benign. I tell these young people that as they get older, they do generally diminish in their prominence, but I think it helps to encourage them to moisturize the skin, to not pick or squeeze. A lot of patients think that this is acne, and so they're using really harsh acne products, or again, they're manipulating the lesions. So if you can encourage them that there really isn't anything to be picked or squeezed here, and to just use moisturizers, perhaps with a bit of lactic acid to act as a keratolytic to smooth the skin, that's enough. You certainly can try a topical retinoid, but my experience is that these patients tend to have sensitive skin. It's the same type of genetic profile that is prone to dermatitis, and so sometimes the retinoids make them more red, so you have to be careful. But even if they used it every other night, it might be helpful. So seborrheic dermatitis, and this is, again, a different quality of scale than we were seeing with our other dermatitis patients who had a really dry surface. Seborrheic dermatitis patients, often their skin is a little bit greasier, and so the scale is also a bit of a greasy adherent scale. It's not always itchy. Sometimes patients are itchy with it, but not in nearly the same way they would be with atopic or contact dermatitis. So the typical location for this is medial eyebrows, nasolabial folds, sometimes beard and mustache area, and then of course the scalp. It doesn't have to be at all of those locations, but when you see a little flaking in the eyebrow, maybe think about looking in those other places. The upper chest is another common location. So using a topical azole, or briefly or intermittently using a topical steroid if they're getting really red, is helpful. My favorite is 1% hydrocortisone powder mixed in Canesten cream. So just some more pictures of that classic scaling around the nares. And sometimes that may be the only place the patients get it, so they don't have to have it in their scalp. So folliculitis is going to present as pink papules and pustules that are surrounding a hair follicle. And there's common places like the scalp, beard, buttocks and thighs, sometimes the lower legs of women who are shaving. And it can have different causes. It can be bacterial, sometimes it's fungal in patients especially who've had a lot of antibiotics, perhaps over long periods of time, like for acne. And sometimes it's mechanical, related to shaving. So if they're really pustular, we could swab these lesions to help us come up with an etiology. And a biopsy can sometimes be helpful too in terms of identifying if it's a fungal folliculitis. So really the treatment is going to be based on what we find on perhaps our swab or our biopsy in terms of etiology. But generally, if it's in a hairy area, if we can try to encourage the patients to stop shaving, I suggest they perhaps consider trimming their hair instead of shaving it to avoid the mechanical disruption. And then benzoyl peroxide wash is a good anti-inflammatory wash that they can use in the shower for chronic folliculitis. So less common rashes. They're still somewhat common, I have to say. They're all things that, well, not all, almost all things that I would see in my office and that you probably do too, but maybe not quite as often. So lichen planus. So perhaps you learned the 6 Ps at some point in your training, but that's a helpful thing to remember with lichen planus. So the purple is sort of number 1. So the color is a little different than a lot of our other eruptions that tend to be more pink or red. We have often these planar or flat-topped papules. They can be plaques, so they aren't always small papules. Sometimes they're larger plaques. It can be scaling, but again, they have that purplish color. And some poor folks end up with lichen planus all over, but some of the common places would be this inner aspect of the wrist, like you can see in the photo here, sometimes around the ankles. And you do want to ask these patients about the buccal mucosa, and in women you can also end up with vulvar lichen planus, so they won't always offer that information unless you ask. Sometimes they're not having symptoms in their mouth, but if I suspect lichen planus on the skin, I would always look at the buccal mucosa, and sometimes you'll see the white streaks that we call Wickman's striae, and again, it's just another piece of the puzzle to help you be more sure of your diagnosis. A lot of lichen planus is idiopathic, but sometimes it can be drug-induced, and other times it can be associated with hepatitis C. We treat it with medium to high potency topical steroids. It responds fairly nicely to narrowband UVB, and if it's really widespread, then we would consider, again, a tapering course of prednisone. So the picture of the feet is showing how sometimes you can get those papules really coalescing more into a plaque, and the other photograph is of the Wickman's striae that you might see inside the mouth. So this is one of my patients, actually, who's just in for a follow-up yesterday, and I'm glad to say she's looking much better, but she has classic subacute cutaneous lupus, so another annular rash, darn. So these patients present with these pink annular lesions, and I'd almost call them polycyclic, right? They often have like multiple circles that are almost overlapping, and they do have some overlying scale. They're not particularly symptomatic, so this poor lady was pretty covered, but she wasn't very itchy. Sun-exposed areas can be most affected, but certainly they can have it on their trunk as well. A biopsy will be diagnostic, and you want to think about medications, especially in an older patient like this, and you do want to do some lab work to rule out systemic SLE, and don't forget a urinalysis. We tried treating this lady topically, but she really didn't respond, and so she had just been on Plaquenil, I think, for 4 weeks when I saw her yesterday, and her rash is almost gone. She, of course, should avoid the sun when the sun comes back out. So that's her shoulder and her legs. So bullous pemphigoid, it can sometimes be quite dramatic. This is actually a pretty dramatic picture with lots of bulla, lots of pink indurated patches and plaques. Other times it's sneaky and we don't actually get the bulla, we just get the patches and plaques. So we call that urticarial stage bullous pemphigoid. So that's a lot more difficult to diagnose. These patients are very, very itchy. They're usually elderly, so I'm saying over 60, but I would say more often even over 70. And in my office, I have a few nurses that work with me and are very helpful, often doing biopsies. And so I always say to them, if we have an elderly patient who's really itchy, even if you don't see blisters, just do that extra biopsy for immunofluorescence. So that's where we take an extra biopsy of the normal perilesional skin, and we put it in Michael's medium, and we see a very specific pattern on immunofluorescence that can help us to diagnose bullous pemphigoid. So just something to remember in your elderly itchy patients. These patients, unfortunately, generally need long-term prednisone to control their symptoms. And so you do want to think about bone protection with them. Your dermatologist hopefully will remember, but just as a reminder in case they don't. You may see them get put on tetracycline as well, and that's not because there's any bacterial cause, but we do sometimes use tetracycline in these patients as a steroid-sparing agent because of its anti-inflammatory properties. And then topical steroids can also be used, not so much on the bulla, but on these itchy pink plaques. So you can picture that one on the left there. If you didn't see the bulla, it would be a lot trickier to diagnose. So mycosis fungoides, another diagnosis that we do see more so in our older patients, and it can also be a bit of a mimicker. So it can just start with these pink patches and plaques that may remind us, again, of a dermatitis, but over time they often become much more indurated and thickened. That's not going to work, is it? Oh, yeah, so as you can see right there, they sometimes will also present with erythroderma, so that's where they're basically red from head to toe with a lot of scaling, so we call that Sézary syndrome. A biopsy is diagnostic, but notoriously difficult to get a good sample, and so if you're suspicious of mycosis fungoides, if you're able to do multiple biopsies, also early in the course of mycosis fungoides, sometimes the biopsy is not as diagnostic, so if their rash is changing over time, it's worth considering redoing it again. So these patients typically are treated with topical steroids and narrowband UVB as long as they don't have any systemic features. So that's a nice thick indurated plaque there on the left, and then on the right is a patient who just presented with erythroderma. So dermatitis herpetiformis, I think, is the new diagnosis that all my patients think they have, but is actually not that common. So this is the rash that we get with gluten intolerance, and a lot of my patients believe themselves to be gluten intolerant, and every skin manifestation they have must be from that, but there is actually such a thing, and this is it, but it's not all that common. It is very, very itchy. And sometimes we'll see little tiny vesicles on top of a red base. Other times there won't be any vesicles to see because patients typically are scratching so much that they've broken these vesicles by the time they come into the office to see you. So it can be a tricky one to diagnose. They don't necessarily have any GI symptoms related to gluten intolerance. And a biopsy is quite specific for this diagnosis. And again, if you can do immunofluorescence, it's also helpful. The treatment is a gluten-free diet, and dapsone is often required as well. Just a reminder, if you ever prescribe dapsone, to check the G6PD first and monitor their hemoglobin. So that's more typically what you're going to see is the excoriations in the classic locations like the knees, the elbows, the buttocks, the back of the neck. This is one of the ones that I don't see in my office. Syphilis certainly is becoming more common, so it's good for us to remember that after people have the painless chancroid, which sometimes they don't recall actually having had, they can then develop this widespread skin eruption. It often looks very dramatic, but doesn't actually have a lot of symptoms associated with it in terms of itch. And one of the things that's a bit different about it is it does have this red-brown color. And so it's sort of the red-brown, the lack of itching, and oftentimes it does affect the palms and soles. They may also have erosions in the mucous membrane. So those would be tips to point you in that direction. They may also have systemic symptoms at this stage in terms of fatigue, joint pain, lymphadenopathy. Treatment is penicillin. So that's showing the soles and the tops of the feet. Thankfully, I also don't see this in my office, but you probably do in Emerge. So just a reminder as one that we don't ever want to miss. With petechiae and purpura, so these are non-blanching vascular lesions. We see them most often on the trunk and extremities. And these patients are sick, so they have a fever, they have a headache. If they're young, they're crying, they're screaming. They may be having seizures, they may be vomiting. And those are a poor little bunny with nasty petechial lesions on the legs. So now we've got all these images in our head that we're going to try to match up when we see our patient next. What things are we going to ask them that will help us? So this is probably a bit of a stereotype of people in dermatology that they just look and don't talk to their patient, but I do try to get, before the patient launches into the history, a bit of a look because it really can help you to focus your questions and get the information that you need about their skin eruption. So while they're talking, I'm making them lift their clothes, and then you can start to ask questions. So of course, let's say you're looking and you think, oh, that kind of looks like guttate psoriasis. You could ask them if they had a sore throat a couple of weeks ago, or if it looks like bites, you could start to ask them if they've had any recent travel. So Again, if you don't look at it right away and know what it is, asking about new exposures, new contacts, travel, affected family members, any personal or family history of skin diseases or atopy can all be helpful. And in terms of physical exams, sometimes it comes down to more the demographic that you're looking at. So thinking about the age of the patient that you're seeing. If you see bulla, of course, in an older individual, like we were just speaking about, you would think about one of the immunobullous conditions, whereas if you saw it in a child, it'd be much more likely to be bullous impetigo. So that can help to sort of triage down in your list of images. Full body maculopapular eruptions, again, in an older adult, are more likely to be related to medication reaction, whereas if you see that in a child, you're going to be thinking first more about a viral exanthem or rash related to bacterial infection or maybe guttate psoriasis. There are other skin diseases that we hardly ever see in children, so lichen planus, dermatitis herpetiformis, nummular dermatitis, and mycosis fungoides. You don't even have to have those images in your head when you're looking at a child. So that's just showing you how those two bullous conditions might appear to be very much the same, but just the age of the patient alone is really going to help to direct your investigations and your differential diagnosis in a different direction. Likewise, showing a picture of scarlet fever and a drug eruption, which again, you could say are quite similar, and certainly not saying there couldn't be some overlap, but again, thinking about the population you're looking at will help you to narrow things down. Also, the kinds of symptoms that the patients are having. So speaking about that a bit as we went through our list, there are some conditions which are very, very itchy. So atopic dermatitis, nummular dermatitis, insect bites, scabies, urticaria, those things patients are going to be very uncomfortable. Drug eruptions, guttate psoriasis, some of the viral exanthems, tinea, they may be itchy, but it's not always quite as prominent a sign, or symptom, I should say. And then in Fift's disease, the keratosis pilaris on the backs of the arms, Lyme disease, scarlet fever, seborrheic dermatitis, secondary syphilis, they may have a bit of itch or they may not have any itch at all. And that, of course, is going to be quite different, for instance, from a patient with nummular dermatitis. You're not even going to consider that if they're not itchy. Also really helpful, again, to go back and think about the distribution of the eruption. So we talked about flexures as being really common in atopic dermatitis, and of course the flexures in tinea as well. And then extensor surfaces, we're going to think more about psoriasis, about the dermatitis herpetiformis, keratosis pilaris. The scalp, again, has some fairly specific diagnoses that attack it there. So folliculitis, psoriasis, seborrheic dermatitis, dermatitis herpetiformis, tinea. So we can narrow our list that way. Mucous membranes, again, there are only a few diagnoses that are more commonly affecting mucous membranes, and the same with the palms and soles. So just showing similarities, but again, their history is going to be quite different. A palm or psoriasis patient may have psoriasis elsewhere. A crested scabies patient is going to have burrows and going to have signs of scabies in other classic locations. They're going to probably have itchy contacts or live in a nursing home. Some rashes have a very specific distribution that really helps you. So pityriasis rosea, I suspect you folks see a lot more often than I do because it takes them a bit too long to get in to see me, and it's gotten better. But they have that very classic, truncal distribution with the herald patch and the Christmas tree pattern. Seborrheic dermatitis is often very classic, whether they have all of the signs or not. Scalp, medial eyebrows, nasolabial folds, beard area, upper chest. Plaque psoriasis, again, they show me a little plaque on the elbow, I'm not sure. I go looking at their scalp, looking at their sacrum, looking at their knees. So that's pityriasis rosea. Remember, it has that collarette of scale around the edge that's quite loose and flimsy compared to the scale of psoriasis, let's say, or nummular dermatitis. And that's some classic facial seborrheic dermatitis, and that's the seborrheic dermatitis on the patient's chest as well. Or hot spots for psoriasis. And of course, scabies, we spoke about the classic location of web spaces, genitals, belt line, lichen planus around the inner aspects of our wrists, ankles, oral mucosa genitals, and the keratosis pilaris in the backs of the arms, thighs, and cheeks. So colored, it doesn't help us a lot, right? Most of our rashes are pink, but there are a few outliers. So we mentioned the lichen planus is more violaceous or purple. So if you see a purple rash, that's gonna help you. We talked about the red-brown that we would see more often with secondary syphilis, also with pityriasis lichenoides. And then our red non-blanching rashes, we think of our meningococcemia or just our vasculitis in general. The quality of the scale as well. So remember, scale isn't all equal. We've got our fine silvery scale like we do in psoriasis. We've got greasy adherent scale in seborrheic dermatitis. And then we may have scaling only at the periphery in tinea or in pityriasis rosea. So just remembering that if we're not sure, we've got our differential down to a few things. So we have some investigations that we can do to help us go the rest of the way. So skin scraping, again, is a very easy thing to do. Just use a 15 blade to just gently scrape the skin onto our black piece of paper, send it for KOH and culture. Again, you can always treat empirically in the meantime, but it'll take about 21 days to get that back. If something's pustular, we want to do a CNS swab. If it's bulla or vesicle, we can do a CNS swab and then perhaps also consider doing a viral swab to rule out herpes simplex or varicella zoster. And then, of course, we always have our biopsy. So very simple to do in the office. There have been studies showing that doing biopsies of 3 millimeters or less heal equally well with or without a suture. So I don't ever suture mine because it takes more time. If you put in your freezing with epinephrine and leave them for a few minutes, see another patient and go back, they very rarely bleed, although you can always use a little silver nitrate if they do. And a punch biopsy can give you a lot of information. I mentioned about doing immunofluorescence, so you just need to order the Michael's medium, the separate little jars from your lab. And then if you're thinking about some specific diagnoses, so lupus, mixed connective tissue disease, vasculitis, porphyrocutinea tarda, and lichen planus, in those situations you want to do a biopsy of lesional skin. And in your bullous, immunobullous disorders, or again, dermatitis herpetiformis, you can kind of think of it as bullous, it's more vesicular. You want to biopsy the perilesional skin for immunofluorescence. So we're going to have a test. It's not really a great room to have you yelling out your answers, so I'm just going to get you to think about them to yourself. So this is a 50-year-old gentleman who presents with the sudden onset of this somewhat itchy skin eruption. He's been given 1% hydrocortisone cream, but it's not working for him very well. So just look at it for a minute and think about what kinds of focused questions you could ask him and where else on his body you might look to help you with the diagnosis. The tattoo might be significant. Just put food for thought. So you've all thought about it now. So you could ask him maybe if he's ever had any liver infections. You could ask him if he takes any medications. You could also perhaps take a look around his ankles. That'd be another place, or you could take a little peek in his mouth. So of course we're seeing some Wickman striae in his mouth. We're seeing some similar violaceous papules around his ankles and his lichen planus. I will tell you that I've had a number of lichen planus patients where I've just checked their hepatitis C titers because they had lichen planus, and we've diagnosed hepatitis C that they were unaware of. So that might just be something to think about screening if you see lichen planus. So here's a young woman who is most distressed because she does not look very nice in her bikini. She's covered in these pink, scaly, tiny macules. She's a bit itchy. But mostly she really doesn't look very good, and she wants you to get it better right now. So think about what you might ask her, where else you're going to look. So I'm going to ask her if she's had a sore throat recently, whether she was treated for it or not, and I'm going to think about maybe looking at her scalp, looking down the extensor surfaces of her legs. So this is guttate psoriasis. So a lot of the guttate psoriasis patients haven't necessarily had a diagnosis of strep, I find. If you ask them, they'll say, oh yeah, I did have a cold. So if they haven't been treated recently, even if they don't have a history of sore throat, I always swab their throat. And if they do grow strep, then I treat them. There's a thought that the strep is acting as an antigen that's going to continue to promote their guttate psoriasis, so I do think it's worth treating them. So again, just as a screening, just give them a quick throat swab. And this is a 30-year-old woman who's got a rash on her forehead. It's around the back of her neck as well as around her eyes. She's very, very itchy. She's in some distress as well. Oh, sorry, and my point about the big distress with the last one was don't give her prednisone, right? So this poor lady, so what are we gonna ask her and where else are we gonna look? So when I see facial eruptions, I always ask what they've been putting on their face or on their hair. And it turns out that she's never really had skin problems, but she did have this really bad rash when she had this beautiful henna tattoo of parrots done on her back when she was on vacation a couple of years ago. So she's having contact dermatitis to PPD, which is in henna, and also black hair dye. So some of these patients might have their hair dyed, and they may not develop the contact dermatitis for several days afterwards, and so they don't necessarily make the association. Remember, again, in the patient where they have that dermatitis on their face, that a calcineurin inhibitor might be a really good option for them. I also send them back to their hairdresser to see if they can find ways to wash their hair dye out more quickly, because it seems that as long as it's in contact with their skin, as they sweat, as the hair dye gradually comes out, they will often have some dermatitis for quite some time. So in summary, when we see a patient with a rash, we're going to try to sneak a peek before they get too far into their history, and then we're going to ask some pointed questions that may help us to try to narrow down our differential diagnosis. We're going to think about how old they are and whether that's going to help guide us to what's most likely. We're going to ask if it's itchy. We're going to think about what color it is. We're going to think about if it's scaly, what the character of the scale is. What's the distribution, and if they're only showing us one part of it, let's look in those other places to see if it confirms our suspicions. And if in doubt, if it's scaly, do a scraping. If it's wet, do a swab. And if you're really not sure, just do a biopsy or, of course, refer. Thank you.